what do you think is the most important and unanswered question in type 2 diabetes?
A simple question.
You know, that is a tough question, Bob. But I think it's really the argument that now exists is fundamentally around whether or not you really can control cardiovascular risk by controlling glucose. And I think that that's probably a thing that we'll never get a good answer to anymore, because we've lowered the background event rate by carefully controlling lipids and blood pressure. And that was one of the beautiful things that one could see if you looked at and VADT, is they had blood pressures that were down below 130 over 80 routinely in all groups. They had cholesterols that were well controlled, and you know, in the U.S. studies, 90% of them on statins. In Advance, a little bit less, but still quite a number of statins and good LDL cholesterol control. The VA had over 90% of them on platelet blockers, either aspirin or clopidogrel, and so the use of antiplatelet drugs, controlling LDL and controlling blood pressure, make it harder to see an incremental benefit in these trials from lowering glucose, because you've already reduced the risk so much. And so it really becomes difficult to dissect that out. I think that because of microvascular disease, the risk there, and all of those studies did have microvascular endpoints that were beneficial in the intensive, even though there was no difference in macrovascular outcomes, but there were still microvascular benefits. The microvascular benefits still drive one to trying to control glucose as reasonably as one can, as long as you're not aggravating frailty, hypoglycemia risk, and other things. And you really got to get down to looking at the individual patient again. I think a point Jim Gavin made so well yesterday.
I think that's one of the questions with JNC8, where it's going to be, quote, evidence-based. Everything needs to be in a peer-reviewed randomized outcomes trial. And you reach the conclusion that lowering blood pressure, intensive blood pressure control in diabetics has no benefit, but you start at 133 over 87% of them on treatment. And then you make a population-based recommendation where only, 10, 11% of diabetes has blood pressure and lipids controlled at the same time?
So, Bob, I think we can almost have the panel phrase the questions for each of these three things: glucose, blood pressure, LDL. How low do you go, and how do you get there? And for LDL, it's pretty straightforward with it. At least statin. You know, you use a statin, you dose it up high, you get low as you can with that. But for blood pressure and glucose, unfortunately, it's a lot more complex. In regards to, you're going to use multiple drugs. One drug's not going to do it. And the same is true with lipids. Once you get into 2 and 3 drugs, the choice of drugs. So it's going to be exciting. We still need to keep more evidence in regards to how do we do this, and which patients do we really need to get the benefit, and how do you get there? Because I think all of us do believe that choice of diabetes, you know, and we look at these trials, there's a lot of reasons why one might not have shown, as you were pointing out, Jay, patient selection, the regimens and everything else. It doesn't exclude the possibility that other approaches for tight control could not give favorable outcomes.
Well, there's a number of, because of the FDA guidelines having regards to diabetes drugs and needing cardiovascular outcomes, there's a number of ongoing trials that are really trying to examine that issue. But they won't be examining some of the older agents routinely used, and I think we need more data about those as well.